Perfect. Okay, so good afternoon, everyone. I'm sorry for those of you who are on the side. I usually like to walk around, but I guess I have to stay here because of the Zoom folks. So I'm Dr Louzada, and I'm a hematologist here in London. I'm really excited to be here with you today talking about the CAR T cells and bites that are coming to Canada, coming to Ontario, and coming to London. Before we start our meeting today, I would like to state that the meeting today is in honor of you. Okay, so just use this. Yeah. Okay, got it. It's going to be in honor and in memory of our dear Craig Gorman. Craig was one of the pillars of the London Industry Myeloma Support Group. Great character, wonderful heart, beautiful soul that was with us for a long time, but somehow he decided to go somewhere else. So he is continuing his journey somewhere else. And I would like to acknowledge the love of his family, the support of his family, not only to through his journey with myeloma, but to so many myeloma support group members and non-support group members as well. They are very active, loving people in the community, always willing to help others. And Jeff was their patriarch, so God bless Jeff wherever he is. Okay, so I'm going to start before we talk about the new therapies. What is myeloma, right? So this is something we always want to review because it's not really a clear concept for everybody. Many people, when they're diagnosed at first with myeloma, they think of skin cancer because it's melanoma, right? Which is a much more common name than myeloma in itself. So I always like to explain, this is an audio of mine that explains myeloma is very, and I think this is very appropriate. Some of you might have seen this picture of me before, but I like to show that myeloma is like a field full of dandelions in the myeloma cells and the myeloma problems that we get are the dandelions. Once we do the treatment to make sure we have a beautiful grass field again, like a clean field. But because myeloma is considered to be a non-curative disease, eventually the dandelions come back. And then they come back one by one, and it is our job to make sure that we are one by one treating them from the field again. And this is when we start treating them. So every time myeloma comes, we clean the field, then the dandelions spore up again, we remove them all over again, then they come back, and then we keep on removing them, right? So this is really treatment of multiple myeloma. And please feel free to stop and make and ask questions during the session. I think that's the best. So we guys, all of us here in person and also our friends online. Okay, so how does the natural history of myeloma goes? So we know that myeloma is a disease that we call clonal disease. Have you heard this word, clones? We know that clones are when we say, oh, somebody did a clone of a horse, of a sheep, right? We had the sheep dolly for such a long time. That means that that sheep was made out of a cell of itself, and the kid or the offspring was exactly like the original sheep. And this is what cancer in general is. It's one single cell that produces other cells exactly like the initial one. And this is what we call clones, okay? So they're all twins, identical twins. So in the myeloma is a disease that comes at least with 7 different clones once a person is diagnosed with it. And why do we have that dandelion type of recurrence? It's because when we treat myeloma, we treat the one clone that's the dominant clone for a while. Then that clone, we kill those cells. Then the second clone that's around submerges and that submerged emerges. Then we treat that clone, we get rid of those cells, and the third clone comes in place, and so on and so forth. This is why we have this relapsing and remitting pattern of the disease. But the important thing here is that once we have our first clone, that's when we're going to start with our first line of treatment, right? Some patients will be invited to go to autologous stem cell transplant, others won't, but we still have excellent treatment for everybody. And what we want to make sure is that this first treatment is the longest and the deepest, because the first treatment is usually the most durable response. So that one, we want to make sure we get to the fullest, to the maximum capacity of keeping the disease under control, because that's the best thing for us. Because in the other, when we move on with the disease process, we go second line, third line, fourth line, so on and so forth. Okay, here we go. What we see is, as the disease progresses, this is like a building block, our treatment gets shorter and shorter. So for second line, you can see you're treating, but the treatment is shorter lived. And this is true also for third line. Oh my God, this is okay, here we go. Now, let's show you. Screen sharing stopped, what did I do? Current slide. Yeah. Yeah, it's the building block one. Yeah, right there. Thank you. I wanted, yeah. Okay. Let me see if I can do just with the enter button. Sure. Yeah, the enter button is working.
Wonderful.
So now we have second line that's shorter, third line is shorter, and fourth line is even shorter, right? So that's what we see on a regular basis in our myeloma pathway, in our myeloma journey. And why does that happen? That happens because as we treat multiple myeloma, we're actually selecting cells that become more genetically mutated, therefore stronger, meaning that they're more drug resistant. And this is why with the current therapies, first line is the best, second not so much, third not so much, and so on and so forth. Is that understood? Okay, so what we try to do is, why are clinical trials important? We want to give clinical trials many times to our patients, because with clinical trials, we have the opportunity to give to our patients the chance to use a state-of-the-art medication that's still being developed, true, but that has the chance to overcome some of those drug resistances that the cells may have. That's why clinical trials are so important. And that's why in clinical trials in myeloma, we go here in the biggest part of the building block, in the heavily pretreated patients, because those are the patients that are most drug-resistant cells, right? Those, they have the most drug-resistant cells. So if the treatment that we're studying now is working in this heavily pretreated population, it is most likely going to work very well in the very beginning, right? For patients that are having new diagnosis of myeloma. So this is why any treatment starts with heavily pretreated, then the company starts studying the treatments in earlier lines of therapy, okay? So why do we get those cells that are mutated? Why can't our body fight our disease? Why sometimes in myeloma we have a higher increase for infection, and why can co vitro help, like Heather was mentioning to us? This is why. This is our immune system. So a few cells of our immune system that I'm introducing to you here. So those little cells, each guy here has a very specific function in protecting our body against viruses, against fungi, against bacteria, against cancer cells. They fight cancer cells in our body all the time. It's not in patients that have an actual malignancy, but anybody, we're fighting against cancer cells all the time, and our immune system is the patrol that makes sure that everything is okay in our body at this very time. So for you to understand a little bit more, this is the concept that I found quite interesting called yin and yang of multiple myeloma. So I don't know if you guys know, but myeloma has actually several different stages. The very initial stage is called MGUS. Has anybody heard of MGUS or MGUS? Maybe some of you started out like that. Yeah? Okay. So that's a pre-myeloma stage. So that means you don't have myeloma, but you have myeloma cells. And why does that happen? That happens because if you can see here in blue, that's your myeloma cell. But your immune system, you see, they're all here, keeping this little cell here under control, not allowing that it proliferates, that it reproduces itself in excess. Your immune system is robust, is strong, and can clearly identify that cell as an enemy. So they kill it, they keep it under control. Even if they don't kill all of it, there's more of the immune system in activity than cells being able to be produced. But with the passing of time, as I said, the cells mutate. They become stronger, they become smarter. So there's a time where your MGUS becomes smoldering myeloma. So smoldering myeloma there in the middle means that your cells are getting smarter and reproducing themselves more frequently. And your immune system, even though still strong, is not so capable of keeping all of them under that neat, strict control. So there are more cells, but they still live in equilibrium, okay? But you see here in the cartoon that some of the cells are a little darker. So those are cells that are a little nastier. So those ones start to proliferate or multiply very, very frequently and very quickly. And that's when myeloma comes in place. Your immune system is now struggling to fight those cells on its own. And then damage starts, right? So you may have renal dysfunction, you may have anemia, your bones may become brittle because your myeloma cells are now winning that battle in lieu of your, or at the expense of the strength of your immune system. And that's when treatment comes in place. So this is another figure here for you, just to explain very briefly how is the relationship between the myeloma cell and the immune system cells. So what we see many times is that the function between the immune system and the myeloma cell can become inverted. So the myeloma cell is able of producing mechanisms to disguise from your immune system cells to trick them so that the cell is not recognized by the immune system. And it very importantly gets these cells here called Tregs. They are our immunosuppressors. So they are the police that says to your good immune system cells, stop working, you're working too hard. Those are the Tregs. The myeloma cell stimulates the Tregs so that your good immune system cells that are there to fight the myeloma cell don't recognize this and stop because, okay, I'm working too hard. So the next cartoon will show that quite nicely. So then your immune system gets exhausted. They're so tired and they stop fighting the myeloma time you're trying, but your cells are putting so many disguises that they get confused, they get tired, and they just give up. This is what happens over time. So here is another cartoon with your immune effector cells, and it's important that we understand the concept of effector cells. So those are the guys that come and fight your multiple myeloma. This is your T regulatory cells, the policeman that says stop. So this guy here is always stimulated by your myeloma cell. And these ones try really hard to keep the myeloma under control, but they're always bombarded by new genetic mutations and new disguises that your myeloma cells are producing. And then in the end, they go from a very happy effector cell to a not angry, just disappointed T cell, then a T cell that is disillusioned, and then looking into the abyss T cell, and then really exhausted T cells. So we have exhausted T cells in our bone marrow because they can't find the myeloma anymore. And then we need help. So based on this concept of exhaustion of our T cells, then the effector cell therapy can be placed. And the first one to come was the CAR T cell production. Everybody has heard about CAR T, right? So CAR T, so CAR means chimeric antigen receptor T cell. So chimeric means that it is not from the human natural body. It is produced in laboratory, a receptor or one of these spikes here that's in the T cell that recognizes the myeloma cell. So this is here a regular T cell that you can see. Then very wisely, science was able to get a virus and insert a specific genetic material in that virus. That virus contaminates or binds to the T cell, and when it does, instead of causing a sickness or disease, it simply puts its genomic material, its genetic material inside the T cell, and the T cell starts producing those genetic materials that are in fact recognizers of the myeloma cell. So they start, so what happens is you get a very exhausted T cell and you make it wake up because now it has a signal. Myeloma, 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 myeloma. And then they can go there and fight the myeloma cell. That's amazing, right? So this is what happens with the CAR T concept. How is that produced? Is that produced in laboratory? Is it ready off the shelf for everybody? Not yet. There are studies that are ongoing with what we call off-the-shelf CAR Ts, but right now the way CAR Ts are done are this way. So you see here this person that's here. This is a patient with multiple myeloma. So this patient has to go into a special machine called leukapheresis machine. For those of you that have had transplant know what it is, because that's where your stem cells are collected. So it's like you have a hemodialysis. You go into a machine, you get a venipuncture, and then your blood flows through the machine, and through a special filter, we collect your lymphocytes, your T lymphocytes that are right here. Those lymphocytes are then activated through a special process. The virus goes into the lymphocytes and puts in it that special hook, that special receptor to genetically modify that lymphocyte. And once that's done, then you have your CAR T cell. So once you have your CAR T cell, then also in vitro or in laboratory, those cells go through expansion or multiplication because we want to have a lot of them to infuse back to the patient. But if we simply infuse those cells back to the patient's own T cells and other immune system cells will recognize those CAR T cells as the enemy and will fight them. So what we need to do is to give them some chemotherapy before we infuse the cells to kill the patient's natural T cells, B cells, and other immune system cells. That's actually not bad because most of the time patients are suffering from myeloma progression, and that what we call lymphodepletion chemotherapy actually helps to control the myeloma. Here in London, we have two patients that have had CAR T cells, but in Toronto, for instance, there are many more patients because Toronto is running the clinical trials with CAR T. So we do this lymphodepletion, and then once that's done, then the CAR T cells can be infused back to the patient. Is that understood? Any questions? No? Yeah?
I assume that's an age group would be determined as to who would be eligible and who would not be.
For the CAR T, who is eligible or not? Yeah, so the problem with CAR T currently is CAR T is not yet approved, but it is under study for earlier lines. In earlier line, many times it's easier. It will be easier, we think. But at this point, why is it so difficult to go into a CAR T trial? Because patients are sick, as you're saying. So for you to be fit enough to receive a CAR T cell, it's hard because it takes 28 days for the CAR T to be produced. So you have to keep a patient with multiple myeloma that's progressing for 28 days. Just sitting down is hard. So many times patients have failed because they could not wait for the CAR T product to be ready, which is very sad. But it's not only in London or only in Ontario. This is currently a reality around the world. But there is a study that actually finished already using CAR T as first line. So we're waiting to see what it's going to show. But it's a study where you first give treatment for the patient, followed by CAR T, followed by treatment again. So the patient starts with treatment right away. And that makes it so much easier because when the CAR Ts are going to be collected, the patient doesn't have any disease burden, right? Because you used 4 cycles of treatment before, so the tumor burden is down and the patient is much safer. Whereas now, many patients are at the verge of dying when they have to collect the stem cells. So you really select just the very, very fit patients that are able to go through this process. Yes.
Towards the end of the cycle, when the T cells and immune cells are being depleted, how is the patient? Are they very sick at this point before the CAR T cells start to work?
Yeah, I'll give you my personal experience. The patient is really sick. Really, really sick. So what we are allowed to do during those 28 days is to give some treatment to the patient. So for instance, if the patient requires radiation therapy for, painful broken bones or plasmacytomas, which are tumors that may burst with multiple myeloma, we can give radiation. We can give steroids. We can give even sometimes some cyclophosphamide. Obviously, all of these trials are industry funded because I don't even know how much a therapy that's in study like this may cost. We know that it will cost about $500,000 when it comes to CCO funding. When we need to send the patients to the US and it's double, it's $1 million, and those patients have been sent to the US, not with myeloma, but with lymphoma. So it is a very expensive therapy, but the companies understand that if we have to have the patient wait for the CAR Ts to be produced, we need to give the patient something. So I was able to give my patients some chemotherapy so that they were able to survive while the CAR Ts were being produced. The problem, and I apologize, I actually fixed this at home today, but this one is the one I sent to Lisa and Adam. You can see what's written here in this bottom side here of the slide. But what I say here is that 10% of CAR T production will fail. So you have a patient waiting for a CAR T that will never come. So out of 100 CAR Ts, 10 will fail. And that's a problem, right? So that's one of the cons of having CAR T cell, because most of them will succeed in terms of production of the chimeric T cell, but 10% will still fail. So this is a little bit of a problem. And the other problem is obviously having to wait the 20 days, right? But as I told you, we can still give some treatment to the patients in that regard. The other thing about CAR Ts, that's not only with CAR Ts, but also with BiTEs that we'll be talking within the next few minutes, is that they do have side effects, right? They're not innocuous treatments. They can bring in some complications. About 80% of patients that are doing CAR T cells will have something called CRS. Has anybody heard of what CRS is? What is it?
Yeah, your body reacts. It's where your body's reacting to the treatment, right? And you're very ill, can become very ill, nauseous, fevers. So it's something they have to watch very, very carefully.
Exactly. Lisa is absolutely right. So CRS stands for cytokine release syndrome. So one of the biggest disguises that multiple myeloma cells use is inflammation. So you know when you have that freaking pimple that's so painful and so ugly, right? Red and that yellowish spot right in the very middle, and sometimes it's so painful. That's inflammation. So inflammation hurts, and myeloma lives on inflammation. So cytokine release syndrome means cytokines are chemicals that our immune system produces to alert other cells in our bloodstream that an enemy is around. So if you have a bacterial infection, an inflammatory process starts to let everybody know in the immune system that a fight needs to start. But in a normal condition, the fight starts and then it stops, right? When you're using CAR T, for instance, there is a significant tumor burden. There is already significant inflammation because the patient is already very sick, and it's natural for the patient with myeloma to have a lot of inflammation. That signaling is exacerbated, and then you can have a lot of inflammatory signals like having fever, chills, headaches, nausea, vomiting, blood pressure can drop. So those are very manageable, and the world has been learning how to manage those, but they can also be life-threatening. So for instance, a patient that has a CAR T cell treatment that has a fever, the first thing that the hematologist is going to do is to give this patient IV broad-spectrum antibiotics and look for an infection, even though we know it's CAR T related, but we want to be on the safe side. So we'll start treating that patient for an infection, and at the same time confirm that the patient has CRS, right? Another complication that may happen, I don't know if you can see here, is the risk of what we call ICANS. ICANS stand for immune effector cell associated neurotoxicity. So it can affect your brain, the inflammation. So it can cause you to have stroke-like symptoms. Not that you're having a stroke, because you have symptoms similar to stroke, or you may be confused. You may forget how to write appropriately. You may forget how to count from 1 to 10 and 10 to 1 quickly. You may have a seizure. So those are things that we follow very thoroughly every day when the patient is admitted to make sure that those are not happening, okay? So the medication or the treatment, I should say, is not without side effects. The side effects can be significant, but at the same time, we have to make sure that the benefits outweigh the side effects, right? So this is what we're studying for. So I'm bringing here for you actual research results so that you can understand how CAR-T is going around the world. This is a Spanish study that's called CARTITUDE-4. CARTITUDE is the name of the series of clinical trials that are directed or spearheaded by Janssen or Johnson & Johnson. And their product is called Cilta-cel because it's this big name that's on top here. So we all, as good physicians, we shorten all the names, right? So Cilta-cel is the CAR-T that will be coming to Canada. So it is currently under consideration, already Health Canada approved, and now under negotiation to be approved to come to Canada, likely in the end of 2025, more probably towards the beginning of 2026. There are a lot at stake and there is a lot of bureaucracy to make sure that these components can come. One of the problems that we have is that these, the patients' lymphocytes, they are going to be collected in the hospital, but they need to go to the United States to be CAR-T'd, right? To be produced in the United States and then back. And when those products go, they have to go with the patient identification. Because in clinical trials, they have numbers, but it cannot be a number if it's not a clinical trial. It has to have the patient's name, date of birth, perhaps, I don't know, maybe address to make sure that the cell that I'm putting here that I think is for Mr. Smith is gonna go back to Mr. Smith and not go back to Mr. Duncan, right? Because that would be catastrophic. So there will be, and there is already a lot of conversation back and forth with the hospitals administrators, with the regulators of the government to make sure that this is going to be able to be done in a way that even though there may be a higher risk of privacy and confidentiality breach, it is necessary to have that information beyond amongst other things that need to be discussed, right? So going back here to the study, this is the CARTITUDE-4 study, and they evaluated Cilta-cel in patients between 1 and 3 prior lines, so early stages still of multiple myeloma, because we consider heavily pretreated patients that have beyond 3 lines of therapy. So what they found, if you can see here, if you can follow with me, oh my gosh, I keep on putting my glasses on and off. That takes away my aging. Or gives away. Okay, let's see, I have the arrow. Can you see the arrow here? Not really, right? But anyways, so here what I want to show you. In yellow, you see the Cilta-cel patients, and in blue are the patients that use what we call standard of care. So patients were using pomalidomide, bortezomib, daratumumab, and this is the time on therapy, time of success on therapy. So you can see that with Cilta-cel, it was much higher than with the regular therapy. So this is something that's important. Here in the second graph, in the middle graph, we have these bars here, blue and yellow, where you can see that the rates of complete response in Cilta-cel were 73% versus 22%. When we look at overall response, meaning everybody that responded, not only very deep responses, almost 85% versus 67%. So Cilta-cel seems to be much better than our current standard therapy. And when we look at cytokine release syndrome, obviously there was no cytokine release syndrome with regular treatment, but we had 76% of any grade, and most of them were mild, grade 1 or grade 2, 75%. So it seems to be a well-tolerated treatment because the CRS was mild and showing deeper responses, better responses compared to the current standard of care. Now, what I also wanted to show, this study here specifically looks into what did the patients think, because it's easy when we look at those beautiful graphs, right, and see, well, Cilta-cel does better or performs better than standard of care, but maybe the patients were let's see what they say. So these are all patient-reported outcomes. So we can see, so in blue, we have cilta-cel, and in green, we have standard of care. So can you see now the arrow? No, you still can see it. Only I can see here. Anyway, so in blue here, we're talking about global health status. So did the patients feel better by doing cilta-cel? So over time, they felt better, whereas patients that were on standard of care, not so much. They were the same or slightly worse over time, and this is up to 12 months. When they think about pain, patients that had cilta-cel had much less pain over time compared to patients that were on standard of care. Then the other one is fatigue. Fatigue is a big one, right? When we're doing myeloma treatment. So patients on cilta-cel decreased fatigue concerns or complaints over time compared to patients that were on standard of care. And then finally was visual. So visual acuity got better with cilta-cel over time compared to patients that were on standard of care. So this is actually very interesting data, right? And it's brand new, it's 2023, end of 2023, because it gives us some hope that the treatment will work and the treatment will be very well tolerated. Now we transition a little bit to bites. Who has heard about bites or who has been exposed to bites before? Have heard of it, right? So they're slightly different from CAR-Ts. Do you want to say anything about it? That if you know, do you? No? Dave?
Sure. In a nutshell, with bispecific antibodies, it's bispecific means that this particular molecule reaches out and grabs the myeloma cell with one hand, and then it grabs the T cell with another hand, and brings the two together, so the T cell can better attack the myeloma cell.
Absolutely, you're absolutely right. You can come up here and finish the talk. So this is a normal antibody or immunoglobulin. Last week, a patient asked me, oh, I never heard of my monoclonal protein. I've never heard of that. I said, well, this is what we talk about every time I talk about your myeloma protein. So the myeloma protein is called monoclonal protein, monoclonal peak value, M protein. We call it several names. The actual name is immunoglobulin because immunoglobulins are the scientific name for antibodies. So this is a normal antibody or normal immunoglobulin. They all have this Y shape. This, the leg of the eye here, the Y is usually fixed, and the arms can be different, so they're variable, okay? So we produce trillions of immunoglobulins every day, and our body is so marvelous and so smart that each plasma cell, which is the cell that produces antibodies, and when they are disrupted, they produce multiple myeloma. The plasma cells will spend an entire lifetime, which could be 67 years of age. They can reach that age, so specialized they are. They produce one single type of antibody. So if you have a plasma cell that was stimulated to produce an antibody against flu virus number 123, it will spend its lifetime just doing that. And every time you are exposed to flu virus number 123, that one plasma cell will, put the engines on and make sure you're producing as many antibodies against that as can be. When there is multiple myeloma, the plasma cells will produce antibodies out of the blue, right? Without any specific stimulation, and that's why they produce it in excess. But when we're talking about bites, it's exactly what Dave was mentioning. So the bites are antibodies engineered in laboratory, and they will have one arm that will recognize the myeloma cell and one arm that will recognize one of your T cells. And because your T cells are exhausted, if you remember a few slides back, they're really tired and really exhausted, they will have the signal again and they will say, okay, so that is the bad guy. And then they will start sending signals or directly killing the myeloma cells. So when they send signals for other cells to come and kill the myeloma cell. And that's how the bispecific antibodies work. They can recognize different domains or different receptors in the myeloma cell, and this is why we have a few different ones in the market now, still in experimental phase, most of them, but lots of them coming to our Canadian market. So right now we have elranatamab and teclistamab that have BCMA as the receptor in the myeloma cell. BCMA stands for B-cell maturation antigen. BCMA is very common in a number of immune cells, including normal plasma cells, but they are overexpressed in myeloma. And this is why they're a good target for myeloma. CAR-Ts, most CAR-Ts are also targeting the same receptor, BCMA. So, elranatamab and teclistamab are BCMA bites. And talquetamab is this other big number of letters here, GPRC 5D, one they'll be able to memorize all the sequence of letters. Talquetamab is another one that's being investigated. Teclistamab and talquetamab are from Janssen, J&J. Elranatamab is from Pfizer. We currently have a compassionate program for the two ones above, ERA and Teclista, and we have had a few patients already here in town receiving those medications. Currently, they are only allowed for patients that have had at least 3 prior lines, and onwards, and all of the patients have to have had an immunomodulatory drug or lenalidomide specifically, bortezomib, and at least one dose of daratumumab. Otherwise, they're not eligible. If J&J and Pfizer are in conversation with CCO and other provinces to have those drugs approved, and I will show you in the last slide what we're expecting from that in terms of timeline. So this is another study that was just released also at the end of 2023. This is the New York group that did this study. So what we want to know is we have a bunch of CAR-Ts being investigated, a bunch of bites being investigated. What happens after we receive these drugs, right? What am I going to receive? What is going to be my next line of therapy? Or if I receive a CAR-T, can I receive a bite? Will it work? Or if I got a bite, can I get a CAR-T? That's the question. That's the $10 million question, right? Nobody really knows. So there are a few places studying this, including our colleagues in Calgary that are really state-of-the-art in laboratory myeloma medicine. But this is the New York group. So their question was, we have patients that use CAR-T or bite. What happens after they receive, what happens with those that also receive CAR-T again or bite again? So I'll try to summarize this data with you. So what they did is they had patients that patients that were on average 65 years of age. I don't know if you can see there. 78% of those patients had what we call high-risk cytogenetics, meaning that they have myeloma cells that are significantly mutated, so very drug resistant in general. Median of 6 prior lines of therapy, okay, so heavily pretreated patients. 89% of those patients were what we call triple class refractory. So everybody has received lenalidomide or pomalidomide or resistant, meaning they stopped responding. Bortezomib or carfilzomib stopped responding. Daratumumab or isatuximab stopped responding. So they failed all of those therapies during those median 6 lines, okay? And then what we call 44% pentadrug refractory. So that means pretty much the same thing, but we're talking about 5 drugs and not necessarily classes of therapy. There's a little difference there. For you guys, this is a little bit over the top, but for us as physicians, it's really important to tell the regulatory agencies that there is a difference between drug class and line of therapy. So this is why I think they are detailing this in the study, and this is becoming more and more common every time. So they had a total of 58 patients. So here are the 58 patients. So this is called a waterfall plot. So you have each line here is a patient, and each color is a different treatment. But the yellow means they had a CAR T or a bite, okay? And the time on CAR T and time on bite. So of the 58 patients, 19 received CAR T or bites. And then after they received CAR T or bites, 10 of them received a second time of CAR T or bite. And what we want to know is, did it work? So they had already received a CAR T or bite, they received it again and again in their lifetime, in their myeloma journey. So usually, after 6 lines of therapy, what we expect in the current standard of care is that line 6, line 7 will not last more than a year if we're lucky. Most of the time it will last 6 months. If we're very lucky, 18 months. But what they found is that regardless of these patients have been exposed to CAR Ts or bite, after the second time they received CAR T or bite, 28 months, almost 29 months of disease control. And when they were challenged the second time, 31 months. 31 months. And you can think that maybe this person is on the 8th or 9th line of therapy, getting another 5 years of life. So this is very new. And this is very, very good news. Very good news. Yes, the overall survival of patients during that time was 62% at 2 years. That's what we have. So most patients were alive after 2 years of evaluation. So we're learning. Maybe this is not the whole truth, but it is very hopeful, right? It's very hopeful information. Questions?
When do you think it's going to be produced in Canada rather than sending?
That's a great question, and I get that question once in a while. I think that for them to produce CAR T in Canada, we would have to be using a substantial amount of the product, meaning that it's worth it for the companies to open a lab just to do the CAR T. Because a lab like that is probably a few $1 billion to build. So it's cheaper for them to send it to their main laboratory, all of them from the United States and Canada, given Canada has 10% of the American population, so it's just a small portion, right? Then open a laboratory here. It's more cost effective. Yeah.
62% were still alive, but what was their quality of life?
That I don't know. That was not reported. Yeah, and that's an excellent question because at 8, 9, 10 lines of therapy, quality of life decreases because the person is older. There is what we call poor bone marrow reserve because that patient used so many different drugs to fight myeloma that the good bone marrow cells also start to wear off. Increased risk of infections, medical vitro many times can come in place, right, or other strategies, sometimes need for transfusion. So yeah, It's a very important question.
Does light chain myeloma, is that response, any different one?
No, as far as we know, it's no different. Yeah, light chain myeloma is present in 20% of myeloma patients. The most common type of myeloma is the one called IgG kappa, and then we have IgA myeloma coming at 20% together with the light chains, and they do not tend to be more aggressive than the usual IgG kappa, for instance. Yeah. Yes, Heather.
How are the patients doing? You say you have 2 patients that have done the CAR T cell, and how are they doing?
They're doing well. Yeah, they're doing well. One of them already failed, and is already on the second line of therapy after CAR T. And the other one is fairly recent, but doing well. Yeah.
Going back to the labs in the US, how many would there be, or how many are there?
How many what?
Labs that are? Labs?
In the US.
Laboratories.
How many laboratories in the US? I don't know. I don't know, but I know that we have several different companies, at least 5 or 6, producing CAR Ts. So it's at least different 4 or 5 laboratories. In Canada, we have in-house made CAR T. So that's what the scientists of CMRG would like to have, right? Their laboratory funding CAR T cells for the Canadian patients. But again, that's a multi-million-dollar endeavor, and all of the scientists that we have, they're just, regular people like us. They are not multi-millionaires, or they don't have like a multi-millionaire company yet interested in producing their CAR T. So, yeah.
I'm assuming that John Hopkins.
Johns Hopkins, very likely, yeah, very likely. But again, participating as, a sole scientific entity or partnering with a company. Yeah. So in this graph here, in this table, it's just to differentiate for you the difference or the pros and cons of CAR T cells and BiTEs, right? The bispecific antibodies. So the good thing about the BiTEs is that they're off the shelf. They're already produced. So you need to have a patient to take medication, to take a BiTE. You can just, right now request permission to the company because they're giving it for free for all the patients. You get the approval, we admit the patient, and the treatment starts. With CAR T, we have that 28-day window, right, that we have to wait. So there is the 2 differences. So in this case, bispecific antibodies are the best. For manufacturing, rate of failure, around 10% with CAR T. That does not apply with 2 BiTEs. For administration, we need to give chemotherapy beforehand for CAR T, but we don't need to give beforehand chemotherapy for BiTEs. The BiTE is the treatment in itself, and there's not that fight between the patient's immune system with the BiTE cell, right? With the BiTE antibody, Pre-treatment is always necessary for both, because they are foreign antibodies. So for you that received daratumumab or belantamab or isatuximab or elotuzumab, you always receive what we call pre-treatment. So Benadryl, Tylenol, dexamethasone, hydrocortisone, we give those to everybody receiving either a CAR T or a BiTE, so that's necessary for both. One con of BiTEs is that they are repeated infusions. So right now they are a weekly infusion. The initial infusion is as an inpatient, but we are going towards the initial infusion to be done also as an outpatient, but because we're still learning here in London, we admit everybody to make sure we're doing a good job. So once we're safe and our nurses feel confident and we feel confident, then we'll be able to start patients from the get-go as outpatients. But once the patient receives the first infusion, then they start to do their infusions in the chemo suite in London, right? We're not doing in satellite units yet. Because of this, because of the need for development of expertise. And the infusion is really quick, right? It's just a couple of minutes infusion, but we need to observe in the beginning because of the risk of CRS and ICANS that we were talking about before. And the need for repeated dosing. So there are also studies going on looking into doing every other week or doing once a month. We are going to get a clinical trial that will be doing once a month, specific bite, that's also BCMA. That's gonna be once a month, so that's gonna come up soon, so stay tuned. Target antigen loss, it's a lower risk and a higher risk with CAR T. What does that mean? If you have a bite or a CAR T against BCMA, it's higher the risk that your cells will lose BCMA if you do a CAR T than if you're doing a bite, just because, as I told you in the beginning, the myeloma cells are smart, right? So what they do is they do the genetic mutations to get away from that treatment and become resistant. So if you have a BCMA CAR T, the new myeloma cells that are being produced, they will tend not to have BCMA anymore, so that you stop responding to that treatment. So that's stronger with CAR T than with bites. And the risk of CRS that we were talking about, generally lower with bites, higher with CAR Ts, but with CAR Ts on average 80%, with bites 65–70%. So it's still pretty good, it's very common. And neurotoxicity also lower with bites compared to CAR Ts. So this is just a snapshot of what the treatments look like. And then to finalize, what are we expecting as Ontarians? So we are expecting that we have teclistamab and elranatamab coming up in the end of, we are 2024, so in the end of this year or next year. So within the next year, we're hopeful that we will have public funding for teclistamab and elranatamab. And then talquetamab also coming towards the end of 2024 and 2025, CCO funded. So the hope that I have is that they will also start a compassionate program soon, so that if we have patients that use talquetamab, teclistamab, for instance, and require another bite therapy, that they can use talquetamab. Or for somebody that's on belantamab, can potentially go to talquetamab, which is not a BCMA bite, right? So we want to have that capacity to vary a little bit the stimulant that we're giving to our patients so that they have a chance of responding better. Yeah, so that's what we're hoping to get. Cilta-cel, the CAR T Janssen, that's going to be coming to Canada. As I said, 2025, 2026 is going to be coming. I think that's all I have. Let me check. Yes. So I'm open for questions. Yes.
I understand that leukemia and lymphoma have a much better success rate for longer remission and possible cure. Why is it so difficult with the myelomas? Because of the seven different clones that are to overcome.
That's exactly why. So I was giving a talk earlier this week, and one way I like to explain myeloma is to say that, and I've said that here before, myeloma is the older person. So when we are 17 years old, every day is party day, right? So you go, it's Tuesday night, you go to a party, you sleep 4 hours, you're up at 7 a.m. going to high school, no problem, you're doing great. You go to the gym in the afternoon, and then you can go to pizza at night with your friends again, right? And everything is fine, so you're always on the go. That's not the myeloma cell, that's the acute leukemia cell. That's the diffuse large B-cell lymphoma cell. The myeloma cell is is us at 70, not even 70, 50, 55 years of age, 65 years of age. Tuesday night, I need to sleep early, I have to work tomorrow, right? I'm not gonna go to any party. Movie? No, thanks. Movie is only Saturday, right? So that's the myeloma cell. Myeloma cell likes to stay at home. And the home of the myeloma cell is the bone marrow. If the myeloma cell is anywhere else that's not the bone marrow, that cell is extremely mutated so that it is capable to survive outside. And if it is capable to survive outside, it's a cell that is extremely difficult to kill. That's number one. For acute leukemias and aggressive lymphomas, the cells behave differently because when they are very mutated, they're very weak. So that's why CAR T and transplant can cause them to be cured. In myeloma, the more mutated you are, the stronger the cell is, the harder to kill. That's why CAR T can control it, but doesn't kill it for good. That's why patients with multiple plasmacytomas have, unfortunately, still a very poor prognosis. That's why patients with plasma cell leukemia, which is the myeloma that circulates in the bloodstream, have a very poor prognosis. Because remember, those cells are circulating in the blood, so they're extremely mutated. Because in principle, the myeloma cell or the plasma cell does not survive in the outside of the bone marrow. Does that answer your question? Anything else? Yes.
I understand that, the way I see it, it would be helpful to have, a test panel for the immune system before treatment and then after to compare to see how well, the immune system is standing up or helping. I don't see it done, unless if there might be a clinical trial, they might be doing that, but we have no access to that.
That's right.
Your opinion on that?
Yeah, no, this is an excellent comment that you're making. There are studies being done, including some Canadian studies, looking specifically into the immune system to try to understand the immune system in myeloma, because that may be one of the keys, right? So right now, bites are bringing in T cells, but there are also studies looking at what we call kites. It's another type of immune cell that we're going to be targeting to wake up again to the myeloma cell. Or maybe there will be medications that will be stopping the Tregs that are the police officers, right, from working, because they're not good in this way, right? They're not good in the myeloma case. So there are lots of studies being done trying to understand the immune system in myeloma. Yeah, and our Calgary team does a lot of studies in that, but there are still studies that what we call in vitro. So still cell lines that are being studied and understood, and hopefully one day there will be some more applicable elements in that regard. With respect to the genetics of the myeloma in itself, the idea would be if we would do bone marrows in everybody, every time a treatment ends, and every time a treatment progresses. Why don't we do that? One, bone marrow is painful. Two, it takes time, right? And in the end, it doesn't change the management. So if you tell me, or if I tell you that I'll do a bone marrow because that will help me decide if you need treatment or not, or if you need treatment A or treatment B, this is a good reason to do a bone marrow. But if I tell you, I'd like to do your bone marrow, and you ask me, why, doctor? Oh, because I just want to look at the genetics of yourself. You're going to say, how no? It's not your blood. So this is important, right? So it would be nice to do it, but we don't do it on a regular basis because it doesn't change our management yet. Perhaps in 20 years, we're gonna be talking about not even doing bone marrows anymore, just a simple blood test. And then that's gonna be so much easier. And hopefully that blood test will help us to decide the next therapy for the patients. Yeah. Yes.
I think LHSC's new mass spectrometry project that's starting is to provide those new baselines for comparative approaches.
That's right. So the mass spectrometry study that we're currently doing, we're actually doing more than one. So what we're going to start doing, we already started doing, is to compare our mass spectrometry results to the protein electrophoresis that we do. And we're doing that for all patients. So that's actually not a study. It is a study, but it's not. We're collecting everybody that's doing ASPAT or assessment of their monoclonal protein that you all do when you go to our clinics. We're getting a little bit of that sample and we're putting in the mass spectrometer. And what we're learning is what is the concordance between the two. That will eventually generate a study. What Dr. Pua is spearheading now is looking into MRD. So that's a true study where we get patients' consent and everything. So we are doing that. So patients will do bone marrows depending on their mass spectrometry result. So if their mass spectrometry is negative, we're doing bone marrows to confirm that they're also in what we call molecular response in the bone marrow. But we're doing just for patients that are on a specific treatment and first line. And then eventually we may expand that. Yeah, because we're in the very beginning. But yeah, that may be, we hope that will be a solution. Yeah, for MRD, minimal residual disease assessment for sure.
Yeah, I've heard in the research world, we're looking at what's sometimes called point of care CAR T cell manufacturing, or CAR T cells to be taken to the patient. And at the cancer center, the manufacturers to produce the CAR T cells, they wouldn't have to be sent off to the lab, far away. What's your thought on the future of this point of care CAR T cell manufacturing?
I hope it will work, but I really don't know. Yeah, I really don't know because it still requires all the dollars, right? So I believe, for instance, we have a center like PNH, that is very feasible. That is very feasible. They have, a ton of financial and scientific support. Ottawa has a very good scientific support as well. So I think those will be possible. Yeah, and it would be so much easier. There is also a group in China that they are evaluating the possibility of CAR T cell off the shelf. I have to say that I don't know exactly how that technology is done, but I know that they are studying that, and I hope to learn about it, in the future. That would be much easier. Yes.
I would like to know, when we have multiple myeloma, can you be a donor, a blood donor or an organ donor?
No, because when you have multiple myeloma, first of all, you don't want to be giving away your blood, right? You need it. So you need to keep with it. That's number one. Number two, patients with malignancy in general are not allowed to donate blood and are not allowed to donate organs. Because of the risk of spreading the disease to the recipient. Although that's not proven. Any questions about Covitro that Heather was talking about? So Covitro is antibodies. So Covitro is antibodies that you receive. It is a blood product, as she was mentioning. It is an excellent support for patients that are at higher risk of infections, meaning that patients that have already had several infections within a year. So, or one very significant infection requiring hospitalization. So we give that to our myeloma patients, not only for patients that have low IgG, as you were mentioning, but patients with myeloma have immunodeficiency. So even if they have a normal IgG level, and they are having infections, they are still eligible to receive this type of support. And it is true, there is this new one that's called Hycuria that's starting. We have already several patients starting with it. And it seems to be a 1 hour infusion. And we'll see. Yeah, it's once a month, so it's much better that way. But only if you are required to get it. Yeah, and in that end, all patients on CAR-T or BiTEs do receive those supportive treatments because all of them will have very low IgG after the CAR-T or the BiTE therapy. Yeah, because the CAR-T and the BiTE, for as much as they are very specific, they will still kill your normal plasma cells that produce your normal antibodies or immunoglobulins.
When would you prefer to use a Kirby-Truck compared to an intravenous antibody?
No, always. Yeah, always, because they're the same. They're equivalent, really. It's the exact same product. It's the exact same dose that we give. It's more convenient, and this is not my personal opinion. It's my patient's opinion that it's so much better to receive it at home than to have to go to the chemo suite to receive it. So the IV IgG is given once a month in the chemo suite, and it runs in about 2-3 hours. If you have your Covitro at home or Cutiquid, which is the same, just a different company, you receive it and you do it weekly. It can go from 40 minutes to an hour and a half, depending. With the new one, Hycuria, it's once a month, about 1 hour. Yeah, so in principle, patients prefer to have the one at home. And the reason why you receive so many boxes is because, interestingly enough, Canadian Blood Services pays for all of the gadgets that you require. So the needles, the pumps, the gauze, the mat that's clean, the alcohol, the swabs, everything. So you receive a big stack of the tapes for the dressing when you're putting the needles under your skin. Everything is paid for by Canadian Blood Services, and you get a bunch so that it lasts for a while. So that's really nice. That's when we see our dollars being well used. Yeah, that's what I like. I don't like other things, but that I like.
I was wondering, in your opinion, is there going to be customized chemo treatment in the future, matching the gene, the genetics with the drugs?
Yeah, that's what I think the myeloma research is going towards, right? So that's what we call targeted therapy. And that's what the immunotherapy is looking at. The issue is many times receptors in cells, let's say in this case we're talking about myeloma, it's very difficult to have a hook in the myeloma cell that belongs only to the myeloma cell. So for instance, daratumumab, many of you have heard of it or have used it. Daratumumab is a very targeted therapy to the myeloma cell, but some of our other cells also carry that same receptor, which is CD38. So our lower respiratory tract cells have CD38 testes. So our germinal cells in the man have CD38. Our red cells have CD38. Some of our other immune cells have CD38. So for as much as it is very targeted, it still kills some of the other cells. So it's very difficult to have specific one for the cell. Yeah. Now, there are the vaccines. The vaccines appear to be really great because the vaccines, I'm forgetting the name of the myeloma specialist in the US. I have his face right here in front of me, Dr. Almost, yeah, maybe it will come. But he does a lot of experiments with vaccine. I'm trying to remember his name, sorry. But it's not very popular because it's so simple, it's so inexpensive. So he tries to get the technology out, but because it's not inexpensive, then there's no interest from the big industries. So for him to do it in large scale, so basically what he was doing is he was getting the myeloma of the patient, doing a concentrate of it, stimulating the immune system in the laboratory toward those cells and infusing that, doing literally a vaccine against the myeloma cell. That was also done for patients with melanoma many, many years ago. I was a resident when I saw that was being very successful. But we haven't seen that anymore. It may be that simple. That one is fully targeted, right? And it's for the individual. So, yeah. I hope that will come up because I think that's a very simple, effective way of killing the cells. Yeah. In the meantime, we try, right? We keep on trying.
Do you have any online questions?
Nope.
Okay. Thank you, everyone.
Help everyone. I'd like to thank you for speaking with us today. We really appreciate that. This is great. Spring has sprung. Yes, right. Thank you so much. I really appreciate it. Thank you, everybody.
Very quickly, I just want to apologize to our online folks. We had some trouble with the audio. About 10 minutes, they lost the first portion of Dr. Louzada's presentation. So we're hoping the recording might be okay, but it may not be. But just wanted to say thank you to the online participants for attending. And we will stop the recording now, because I'm looking at my son, and wish you a wonderful day.